Okay. Okay, so I wanted to sort of tie all of what we're doing today together for you. So Jim was talking about austerity and the fact that there are choices. These are budget choices that are being made, not necessities, and that they really are part of a bigger plan to dismantle the welfare state as it has been constructed, and really rejig power and wealth in our society in very fundamental ways. And the health system, of course, is part of that. The largest social transfer in the country, that is the largest transfer of income in the country, huge creator of social equality, and also a healthcare program that actually provides healthcare. So it has this kind of vital economic mechanism, healthcare, and also provides this humanitarian service that is so crucial to everybody. Well, and so it's under really very serious threat in Canada, but the problem is that most people don't actually know that. Most people are quite optimistic, which is great. Most people, think the world is getting better, and they don't really sort of see these big swings of history happening around us. And so in Ontario and in Canada, come on up, Colleen, you might want to come around this way, actually, Peter. It's not just that, there's a bunch of chairs there you can't get through, but. And Colleen came all the way from British Columbia last night at midnight, so thank you. And they're happening all across Europe, and yet in Europe, people actually know that there's a fight on, kind of for the hearts and souls of their countries and their societies in a much bigger way. And if you actually Google austerity, in Europe, general strike in Europe. There's a general strike in the fall in 4 countries in Europe over austerity budgets. You'll see it's really interesting, all kinds of photo pictures and coverage and so on. But in Google Images or whatever your search engine is, if you don't want to use Google, I understand. But it's really neat. But if you come to Canada, and specifically to Ontario, we actually have an austerity budget that actually rivals Britain's in Ontario, and yet almost nobody knows about it. Like, who here would say that most people in their hometown know that Ontario is in an austerity budget regime?
You wouldn't.
Most people in Guelph? That's it. Okay. So, and yet what we're looking at is a plan to curtail health spending over these 3 years by $3 billion, no less, $3 billion, huge, and cuts to a whole array of ministries. And actually out in the hallway there's the falling behind report and fact sheets. And I put a list of all the cuts across all of the ministries. They're all important, but here we're talking about healthcare. Okay, next slide. And this is happening in a context in which there already were urgent and unmet care needs across the healthcare continuum. 30,000 people waiting for long-term care beds at the time I wrote this a couple years ago. Now that number has gone down, still over 20,000, but partly it's gone down because people aren't being given the information upon discharge that they, can access long-term care beds. That's one of the ways that they have lowered the wait list for long-term care. 10,000 on wait lists for home care across Ontario. On any given day, almost 600 people waiting in an emergency room for a hospital bed. All of these people that they call alternate level of care, have you heard that term? What they used to call bed blockers, totally offensive notion, but now what they call alternate level of care patients, which they always talk about as if they should be out of hospital, like just get them out of hospital. And in fact, Tom Clausen, former head of the OHA, Ontario Hospital Association, the lobby group, which I say it's a lobby group for hospital executives. It's not lobbying in the interest of hospitals, but of those patients, there's a huge number, about 2,271 at the time I wrote this, waiting for a long-term care bed, but there just were no long-term care beds available in their area that they were willing to, move into. 773 waiting for another type of hospital bed. So people are called ALC even when they need a hospital bed. They might be, say, in a medical surgical bed or something, they need a rehab bed, but there's no funded rehab beds available in the hospital. So it's all of those people. So it's a false notion, the idea that they all need to be moved out. In fact, a good portion of them actually require a hospital bed or care that is generally provided in a hospital. And about 135, and this is the OHA's, the Ontario Hospital Association survey from their own survey from their hospitals, 135 waiting for home care. So basically, if you need home care, they've kicked you out of the hospital. And you're either waiting at home for it or you've got the home care. The rest are waiting for another type of hospital bed or a long-term care bed that doesn't exist. Next slide. Sorry, Adrian. And if you look at where we sit on these issues, we actually really, the evidence is very clear that we actually have cut services beyond virtually every other jurisdiction that it could be considered a capitalist industrial country, as Jim was talking about earlier today. I mean, and so the idea that you can just continually cut, particularly hospital care, and that's where, next slide, the cuts are always going. And the rhetoric of these aren't cuts, this is transformation, we're shifting care to the community and so on, really are false notions at this point. We have cut hospitals in Ontario, we've cut them for 20 years, and at this point we're really seeing the consequences for patients and suffering. And I just want to give you an example. This is the Scarborough Hospital's cuts this year. $17 million deficit, and so what did that mean? Well, it meant 20 surgical beds and 2 entire operating rooms closed down. That's thousands of surgeries a year that will not be performed at that hospital. The arthritis clinic, the rheumatology clinic, closed down. Patients just had to go find other care. There was no replacement in the community. They just had to go and see if they could get on wait lists at other places that already existed. 200 nurses, health professionals, and support staff positions cut. And dozens of hospital departments, from cardiology to geriatrics, labs, physiotherapy, all saw cuts. And then more cuts to come next year, $28 million projected deficit between the Scarborough and the Rouge Valley Health System. That's 4 major hospitals across that area. Next slide. If you look at this, all across Ontario, we're seeing some real trends. They are closing services, they're reducing the number of hospitals that provide services. And so what are they centralizing? So in a region, they might centralize all of the cataracts into one hospital or one site, all the thoracic cancer surgeries, all the vascular, specific types of vascular surgeries, the maternal and child care, they're centralizing, mastectomies, they're centralizing, hip and knee surgeries, they're starting to, cataracts for sure. They're cutting entirely outpatient clinics. They've cut the fertility ones where they exist. They're cutting physio, laboratories, other outpatient clinics like the pain clinic in Guelph or the arthritis clinic in Scarborough, etc. Major bed closures, another round of them, and they're all different types of beds. Major staff cuts, and the attempts to close the small and rural hospitals and the emergency departments that we have, we have collectively fought and successfully stopped at this point. And so when you think about these services, maybe in a roundabout way, some of them are transferable to home care, some physiotherapy, for example, etc. But most of them are just not even transferable to home care. You don't replace a surgery, an OR in home care. You don't replace, cut acute care beds generally in home care. These are really sick patients that, no longer have beds. And so that's why we see all across Ontario, next slide please, a 98% occupancy rate in hospitals. 98%. That's the highest I could find anywhere in the world. Could not find any other jurisdiction that runs that close to the edge. We've now cut health spending in Ontario, in both on a per capita basis, that is per person, And as a percentage of our GDP, so as a percentage of our economic output, we're second last, it's 8th of 10 provinces. So almost at the bottom of the country in terms of health spending. Go ahead. And health care is declining, not growing. It's not on a trajectory to eat up the whole provincial budget. In fact, it's been declining for more than a decade as a percentage of healthcare spending. Hospital, even more steeply, hospital spending or funding has declined very, very significantly as a share of healthcare spending. Ontario, we've actually dropped now to the bottom, but at this time, Ontario hospital funding was the second lowest in Canada per person. And we've cut huge numbers of hospital beds, 18,500 hospital beds cut since 1990 in Ontario, halving our acute care bed capacity and our complex continuing care, or what they used to call chronic care bed capacity. And despite all the rhetoric of successive health ministers, home care, you'd expect that line to be going up, right? If you're cutting hospitals and transferring everything into home care, should be receiving a greater proportion of provincial healthcare funding, and it's not. In fact, it's declined significantly since a decade ago. And even with the last two budgets, the 4%, so-called 4% increase in 2012 that was never really flowed, and then the 5% increase in 2013, we might just be, it depends on whether or not they float all that money, we'll see it towards the end of this year, but we might just be back to where we were in the early 2000s in terms of home care funding. So it's not growing, and on a per client basis, it's shrinking. So what does that mean? If per client, or patient, I hate that word, client, but you have less home care funding. It means that there's a higher burden of out-of-pocket payment if they're gonna get services, right? It means that it's privatized. It means they either go without or they pay for their services. It means that services are much more rationed than they were 10 years ago, 15 years ago. We'll just carry on. And so there's this severe rationing of access to long-term care, rationing of the levels of care in long-term care, ditto for home care. And now, of course, having created the crisis through really the most aggressive tax cuts in the country, Ontario, Jim was talking today about the national picture, the Canadian picture, but to layer on top of that, on top of the tax cuts he talked about nationally, at the provincial level, the Harris government, remember, promised 30% tax cuts, huge tax cuts, led, unfortunately, in a first in Canada, led the country in tax cuts, and we now actually fund all programs and services in Ontario. That's education, healthcare, justice, roads and transport, our provincial parks, all of those services that we pool our money and provide for each other through the tax system, less than any other province in the country. We're dead last in the country now in funding those services. And so having, laid bare the cupboards by giving away the money in tax cuts, we now have created the crisis, and in response to the crisis, the government is now saying, well, we have to privatize. It's the same old equation. We've seen it now for 15 years in Ontario, and now they're going after the hospital system. So you have in your kits a briefing note that looks like this. And so the government is planning to dismantle community hospitals. They've been doing it kind of slowly and behind the scenes. They now have an overt strategy that is, and all of this set up to move very quickly to dismantle community hospitals. So in August, they introduced 2 new regulations. These new regulations provide a structure by which the government, they provide the powers by which the government, through the LHINs, through your local health integration networks, can order hospitals to cease providing services, so cut services from your local hospitals and transfer them to private clinics. Now, private clinics don't work generally, at least not for these types of procedures, in a low volume sort of level. The way they make their money is by high volume, light care patients. So what they do is they take the easiest, lightest care, the healthiest patients out of the hospital system, leaving the heavier care patients behind. Why? Well, the private clinics aren't set up for people who are going to code on the operating table. You know, they're not set up for the overweight smokers with complex medical conditions who are all attached to tubes and everything. They need people who can walk in, get their surgery or their diagnostic test and walk back out. And so the government has not specified what range of services are going to be transferred, cut from hospitals and transferred out. But what's clear is that it moves very fast once they start doing it. And Colleen's going to talk about what happened in BC. But you know, it won't be a matter of years even. It won't be very long before it's hips and knees and routine surgeries. And so what does that mean? Well, it's the dismantling of our community hospitals as we know them. It's the opposite of a vision in which you have a local community hospital that's democratically governed by a local board of directors that answers to the community. You know, they used to have someone from the local bank on the board or, watching the finances, and they would answer to their community and try and plan to meet the healthcare needs of their community and provide a relatively comprehensive range of services. It's the opposite of that. Each hospital will have to narrow the scope of services they provide in order to compete. And then with a much narrower range of services, patients would have to travel from clinic to hospital within their region, and it's organized on the LHIN, so these are very big regions to access services. Everyone get that? So it's a specialized, highly specialized notion. It is not grounded in community. It is the opposite of the idea of a comprehensive local community hospital. And it ushers in a whole new set of players into the system, all these private clinics. Well, the minister has promised that these will be not-for-profit clinics. However, this minister has said that for years, and yet every single service that they have cut from hospitals has been privatized. Physiotherapy in your town, the outpatient physiotherapy that's been cut from the local hospital, where do you get it now? The private clinic. How much do you pay for it?
A lot of money.
$70 to $100 for your first assessment, $50 to $70 for every trip, right, thereafter. Your laboratories, outpatient laboratories, been cut in your town, where is that service gone? To the private lab. Probably not even in your town, probably down the road, right? And they've reduced their hours, if they are in your town, to just a few hours a day, and you fast overnight, and if you don't get in that day, you gotta wait till the next day and fast again to try and get in and have your blood drawn. So this is the opposite. So the minister's promise, first off, about not-for-profit is, I think, an empty promise. I just think it's smoke and mirrors. But anyway, this is not the era in which small not-for-profits are going to take over healthcare services like surgeries. This is the era in which big, colossal companies like Centric, and Colleen's going to talk about this, are moving in and buying up and taking over the Canadian healthcare system. And they wouldn't be not-for-profit for long, not even for probably a few years, if they were at all. And in any case, the not-for-profits that they're creating now, like the Kensington Eye Institute, they're not like any not-for-profit you or I has ever seen. They don't have a community board that anyone has ever heard of having an election. They charge user fees. They maximize their profits in ways that one wouldn't think a not-for-profit should behave, etc. So they leave the hard and costly patients behind in the local hospitals with less staff, less money, less resources to take care of them. They threaten the future of rural hospitals. Just this model is a high volume model. It doesn't work in a place where you have to disperse services over a wide geography. And in 2008, and this is my last point, we did a study in which we phoned every private clinic we could find in Canada. And we asked them, can we buy our way can we jump the queue? Can we buy a service? How fast can we get it? How many doctors do you have on staff? We wanted to figure out their business model. What we found was that the vast majority of private clinics in Canada are charging user fees and bringing in two-tier healthcare. If you're wealthy, if you can pay, and it's not a small amount of money, it's a lot of money, you can jump the queue and get services. They're taking doctors out of our local hospitals. In Ontario, all the private MRI, CT clinics that were brought in took medical technologists out of the hospitals, and they reduced the MRI hours in the local hospitals as a result of not being able to find replacement staff when they open. So they worsen staffing shortages, threaten two-tier healthcare, and they actually cost more. Everywhere, they cost more. So I'm going to leave it at that. There's no question that we can win. We defeated this stuff under the Harris government, a government that was, one, not a minority, two, not facing an imminent election in the spring, three, much more ideologically committed to the program of privatization than this government. That we have a lot in our favor. We have a provincial election coming up. We've decided yesterday to mount a door-to-door campaign and a referendum across Ontario on this question. I think we can win if we do this right, and I look forward to working with you on it.